So Daniel is a professor of sexual health and HIV medicine and a consultant at Brighton and Sussex University Hospitals. He trained at St Mary's Hospital Medical School in London and worked at Guy's and St Thomas in the Chelsea and Westminster hospitals in London before completing higher specialist training at St Mary's. Professor Richardson became a consultant in sexual health and HIV medicine in Brighton in 2006 and was given an honorary readership at Brighton and Sussex Medical School in 2018. He was the British Association for Sexual Health and HIV conference organizer from 2012 to 2018. His research and clinical interests are in the sexual health of men who have sex with men and postgraduate medical education. Take it away, Daniel.
Thank you. I'm always very nervous when I have to use Zoom because I'm just not used to it at all. So I hope my slides are going to work. So thanks for the introduction. So I wanted to start with this slide, which is a picture of Martha Johnson, who's also known as Malcolm Michaels, and it relates to the whole theme of this conference, which is around marginalisation. So Martha was part of the Stonewall movement in the late 1960s in New York, where people of gender and sexual diversity started to have a voice within society around their place in society. And I think we generally think that we've come a long way in terms of the marginalisation of people who live with gender and sexual diversity, but I struggle with this a little bit. And we think of Brighton as being a very accepting, diverse place. But the problem is, and I don't want to get into a political or social debate about some of the individuals on this slide, particularly as I see Bobby sitting in the corner, but people who generally live with privilege and are generally of white ethnicity still have a platform and a voice to express their views around sexual diversity, whether that be religious or whether that be academic. And the problem is that a lot of the people that we deal with in sexually transmitted infection clinics, those people who have an over proportionate rates of STIs, don't have those voices. And we still see a lot of hate, both internationally, as you can see from a recent event in Arizona, I think it was, and also locally. So the picture on the bottom right is from a Pride event where people still are able to voice their hatred thoughts around people of difference. And it's interesting that patients in Brighton, when we talk to them about stigma, the patients that come and see us, they talk to us about the pink cloud of Brighton that they live on, that we live under. And if they live outside of Brighton, we don't understand some of the stigmatizing environments that they continue to live in. And of course, stigmatizing environments, people who are marginalized, they struggle to have the agency to access decent sexual health care and often have high rates of STIs. So that's the kind of premise around, I think, what Ola wanted me to talk about when framed around enteric infections. So enteric infections, many clinicians and probably most people outside the world of sexual health don't think of as sexually transmitted organisms. So these are organisms, enteric infections, that live in feces or fecal matter. And most of the time we acquire these infections by food or contaminated water, and they come from other fluids in the environment, from fields, from flies, and from fingers. But there is another way that we can acquire these infections, and that's by sexual contact. So enteric infections can be facilitated by sexual transmission, particularly oral anal contact or rimming, but also just general sexual contact if you belong within sexual networks where these infections thrive. So Selma Dritz, who's probably my hero, was a public health physician working in the San Francisco area in the 1970s and 1980s. And as my previous presenter was talking about the described outbreak of HIV, she was instrumental in showing that HIV infection was sexually transmitted. And she did this by going out to the community, talking to men who were living in San Francisco at that time with AIDS at that time, and establishing very clear social and sexual networks between these men, and she was able to conclude and really support the idea that HIV was sexually transmitted. But before she did that, in the 1970s, she did a lot of work looking at other infections, such as enteric infections. And this is one of her papers in the Lancet, where she showed that the rates of Shigella, which is an organism which is fecal-orally transmitted, we normally attribute Shigella to be an infection that people bring from overseas, from where food and water hygiene is less good. She showed that Shigella infection in San Francisco, which was increasing at that time, was predominantly in men who were acquiring the infection locally. And she did both quantitative and some qualitative work within this field, showing that Shigella was sexually transmitted. And what's really interesting is that when we go back to those old papers that people forget about, we can find some real gems there. And this is one gem for me. And she showed back in the 1970s that sexually transmitted Shigella had relatively high rates of antimicrobial resistance when tested against the antimicrobials that we used at that time. So she recognized that not only was Shigella sexually transmitted, but there was an issue with antimicrobial resistance. On this diagram, I've mapped out various sexually transmitted infections that have emerged or re-emerged over the past 50 years. And actually, when I did this exercise, I was pretty surprised in the number of new infections that we, as society and as clinicians, have had to face. And the problem isn't going away. So if we look over here on the right-hand side of the diagram, we've had to cope with lots of new issues more recently, including monkeypox, which Sunita mentioned, and here's mycoplasma, and here's HIV infection, which of course changed the epidemiology and transmission of STIs during this period of time, as Sunita pointed out earlier. So if we look at sexually transmitted enteric infections, there's actually a lot of them. So hepatitis A is a viral infection that causes an acute hepatitis. And most of you who've traveled overseas will have been immunized against hepatitis A as part of your travel vaccines. Giardia, which is a parasite, can be sexually transmitted, particularly in gay men. And then this group of bacterial infections that I've talked about, and amoeba or entamoeba, which is also a parasite. So these are the enteric infections here. I've just mentioned here the causes of proctitis. The proctitis means inflammation of the rectum. And there's a big group of organisms here, which, unlike these, are acquired directly into the rectum via anal sex. And they can cause this syndrome of proctitis, so rectal pain, rectal bleeding, including chlamydia and gonorrhea, which we've mentioned previously. So at Brighton Sussex Medical School, we've done quite a lot of work on enteric infections over the past couple of years, and this is a systematic review that I did with Carrie Llewellyn, who works over in, who probably in the department we're sitting in now in Watson Building, and we looked at the antimicrobial resistance patterns amongst gay men who've acquired Shigella, and as you can see, very similar to the story of gonorrhea, this organism has rapidly become resistant to most of the mainstream antimicrobials that are used, interestingly, for other sexually transmitted infections, because it's part of the same pool of people. And we're now seeing resistance to cephalosporins, which I'll describe in more detail here. So we have a real issue with antimicrobial resistance with Shigella. Shigella is particularly interesting from a biological perspective in terms of how it acquires antimicrobial resistance, because there are two mechanisms. First of all, there's de novo mutations, which most people will understand that if people misuse antimicrobials, or if antimicrobials are present in the environment because of farming, etc., then the organism will mutate and then develop resistance to the antimicrobial. So that's called de novo mutations. But there's another mechanism that these group of organisms use, and that's horizontal transfer of antimicrobial genes. So when they've developed an antimicrobial genes, they can pass it on to other species and other groups of organisms. And these two mechanisms for antimicrobial resistance explains why we've seen rapid emergence of antimicrobial resistance genes for resistance to things like Shigella. It also explains why we've seen a lot of resistance to gonorrhea. How does this happen? So the reason why it happens is because most genetic material, of course, in organisms occur in the nucleus, but some organisms have these little circular structures of DNA living in the cytoplasm. And these circular structures are called plasmids. And plasmids can transmit independently from the rest of the organism, like this. So here's one organism and here's another, and it's this organism has transmitted its antimicrobial resistance to another Shigella organism, and that is not its progeny, and that's the point. So it's horizontal transmission causing resistance. Fortunately, similar to gonorrhea, we have really good understanding of the genetic makeup that confers resistance. So all of these horrible numbers here represent a genetic a genome, a part of the genetic code which confers resistance to different antimicrobials. So we're able to map outbreaks and individuals who have Shigella infection and determine whether or not they're going to have antimicrobial resistance based on their genetic makeup, including from plasmids. So we talked about cotrimoxazole or septrin resistance, quinolones. The common quinolone used is ciprofloxacin, macrolides, which is azithromycin, which Sunita was talking about with mycoplasma. And more recently, particularly for Shigella, we've started to experience penicillin or cephalosporin resistance. And this is very important because it means that we have very few antimicrobials left for the treatment of Shigella. So there are 3 outbreaks of resistant Shigella I'm just going to mention. Here's the first one. It's very small, so a group of 9 adult men living in London who had this particular species of Shigella, Shigella sonnei, and they all contain this particular plasmid, which contain genes which rendered this particular organism resistant to azithromycin and ceftriaxone. Because of the excellent surveillance we've got in the UK that Sunita mentioned earlier, we were able to track this infection, this outbreak really carefully, do really good partner notification, make sure that these men had stopped having sex while they were infectious and contained this particular outbreak. And you can see the outline of the people who were infected here, most of them probably acquiring their infection by meeting men using geosocial mobile phone applications. And this kind of information is interesting when we're thinking about control of STIs. Here's a second outbreak. This is in Melbourne, Australia, and it's similar to the previous one, apart from this outbreak contains this particular gene, so the BLAR CTX-M27. So this gene confers resistance to ceftriaxone, which is a cephalosporin, so we're wiping out another class of antimicrobials. This complicated diagram isn't really complicated. All the little dots represent an individual who's got Shigella, and these ones up here are not necessarily related to each other. They're all sporadic cases of Shigella in Victoria, in Australia at that time. However, this group here are all the same, so they're all related because they're all part of the same outbreak. This is an outbreak of Shigella that's occurring locally. These people are transmitting Shigella by sex, and as you can see from, they've all got these genetic mutations, and they're resistant to all of these antibiotics. So very important outbreak. And then, of course, we've got international travel. We're a very mobile population. This is before COVID. Sorry, this is after COVID, actually. So you can see that travel's still going on. And we've got a very similar outbreak in the United Kingdom. And this graph, very elegantly published by my colleagues at UKHSA, Hannah Charles, shows in the blue bars, these are isolates of Shigella that don't have this particular genetic mutation that confers resistance to ceftriaxone. This is the same outbreak, but eventually this particular strain of Shigella then acquires this nasty gene, meaning that all these people who had Shigella all have very resistant Shigella. This outbreak occurred across the UK, but particularly Manchester, London, Brighton, as is seen by lots of STIs. And some of them were pretty sick and ended up in hospital. And lots of them had inappropriate use of antimicrobials, unfortunately. I'll just mention monkeypox because outside of the kind of biomedical sphere, I think monkeypox has highlighted some ongoing issues around marginalised people who struggle to access healthcare. A lot of the people that we saw with monkeypox in the summer were neurodiverse, they were young, they were students, and they're often ignored and are silent in the community. And I think it's really important that we as clinicians work really hard to increase access to people who don't have agency. And that was one of the issues with this infection, although we appear to fortunately have seen a massively reducing prevalence. There are lots of knowledge gaps when we're thinking about enteric infections, as Sunita mentioned. We don't understand the role of antimicrobials, and I would definitely advocate not using antimicrobials for most people with Shigella because they're unnecessary. It's a self-limiting condition. We don't understand what the significance of asymptomatic infection. So in various series, lots of men have Shigella in their stools, but they don't have symptoms. And there are also lots of other infections that are enteric in nature and are sexually transmitted. And we have very little knowledge of these, mainly because they're not particularly sexy and they don't necessarily affect white privileged gay men. And therefore, the focus often is moved, and these are not people on PrEP necessarily. So we need to think about those issues. The message for me to healthcare workers is that if you see gay men or people of who live with gender diversity or live with sexual diversity, if they've got diarrhea, make sure you get a stool sample for antimicrobial resistance testing, and don't just go for antibiotics just because people have got diarrhea. I'd just like to acknowledge some of my colleagues who've helped with some of the work that I've done in the past. I hope it wasn't too medical and that we can have an interesting discussion about this interesting topic. Thank you.